the CHIPRA grant at Envision, New Mexico, and also working on PCMH.
I'm Jane McGrath, Director of Envision.
Poeta Kasemsab, I'm a pediatrician at ABQ Health Partners in Rio Rancho.
Terry Chevet, I'm the admin assist. I'll be supporting this CHIPRA project. Q-tip project.
That too.
And Kevin Whirling, Systems Analyst at Envision New Mexico, and your IT support person.
Would you out in the audience introduce yourselves?
My name is Janie Wright with ABQ Health Partners, Montgomery Family Practice.
Thank you. Welcome.
I'm Elizabeth Riddell with the School-Based Clinic in Espanola. Hi.
Hi, welcome.
Thank you.
And I'm Elizabeth Martin from ABQ Health Partners over at the Journal Center.
Hi, Elizabeth. The person who signed in before Elizabeth, who was that again?
From Espanola.
Elizabeth Riddell from the Student Health Center at the Espanola Clinic.
Welcome.
Thank you and welcome.
Thank you. Thank you.
Anybody else?
Yeah, this is Gil Alvarado, nurse practitioner over at the Student-Based Health Center in Rio Doso.
Hey, great to have you, Gil.
Hey.
Any other participants? Okay. Well, just as a reminder, to mute or unmute your microphone, it is *#.
*#, that's right.
Anything else I need to let them know, Kevin?
I don't think so.
Okay. Without wasting any other time, Dr. Robran-Marquez. Thank you.
Thank you. Do I need to go over this slide at all, or?
No.
Okay.
Unless you have something to disclose. We have various jokes that we tell at this slide, but we don't have.
Perfect. Well, my name is Darcie Robran-Marquez. I am a family medicine physician by training. I am actually from New Mexico, never had a thought to leave the state of New Mexico, trained at UNM and did my residency there as well. And I guess if you're asking me what I have to disclose, I should disclose a little bit about my employment background. I recently joined Molina, Healthcare of New Mexico, as medical director, but came from a 7-year stint with Presbyterian Medical Group, helped build and establish their patient-centered medical home across the state. And as I put together this presentation, I actually struggled a little bit. I had some questions about who might be in the audience, because I hope I am not over-speaking to some of you that aren't familiar with the concept, or I hope those of you that are familiar with the concept, I am not telling you things that you already know. So I tried to make it a balance, and if I am talking too much or if you have any questions, please feel free to stop me during the presentation. All right? So I thought I'd start with the objectives and what I wanted to do today, or what I wanted to tell you about. I'd like to tell you a little bit about the why, what, and who of the patient-centered medical home, but would throw it back to you and say that it's up to you about the where and the when. And so I'll go into some of the details, but I do know, sounds like we have some participants from the school-based health systems, we have some participants from a large medical group, we have some clinical staff, some nursing staff, and so what I'd like to do is provide you with something that you might take a piece of and be able to take back and maybe think about how you might implement at your site or in your practice. All right, so first of all, let's talk a little bit about the why. And I think I'm probably speaking to the choir with this slide and some of the slides that are going to be coming up, but I just wanted to set the background so that we all know why this is important and why the time is now for the patient-centered medical home model to be important. This is just some data that I wanted to share with you on the cost and the prevalence of chronic conditions. Those of us that are still practicing, we know that the prevalence of most chronic conditions, asthma probably in pediatrics, but we still see some diabetics in pediatrics. We still see a lot of the precursors, such as obesity in pediatrics, that later turn into some of these chronic conditions. And as you can see on the graph, they estimate that the prevalence will just continue to rise, and the costs associated with those chronic conditions will also continue to rise. So that's why there are many people interested in this concept. All right. I don't know if those that are practicing remember when this study came out in 2005. I thought it was telling because it was what we all were feeling at the time. And finally, someone did a study and someone put some numbers to it. And so there was an article or a large study that came out in 2005 that basically counted up the time a provider might need for a panel of 2,500 patients. And that's the average panel size for a family practice or a pediatrician. And that study showed that if you were following all of the chronic care guidelines, that would take you 10.6 hours per day. If you were doing all of the preventative care for that panel that you saw that day, it would take you 7.4 hours. And the time needed for acute care is 4.6 hours. And if you add that up, I don't know when you'd sleep. I don't know when you'd have life outside of medicine. I don't know when you.
And that was before your EMR got instituted.
That was I definitely need to add the next column for the time it takes you to do something in the EMR with this. So you make a very, very good point. It adds up to 22.6 hours per day. We know that there's not that many hours per day that we want to spend at work, and so something has to get dropped. Something has to get, something has to be missed. And unfortunately, in the past, it's been preventative care that has been dropped for many reasons. It's not reimbursed very well. That's not what the patient came in for. Many reasons why we let that drop. And so the hope with the patient-centered medical home is it's actually a model to help you be able to do probably not all of this, but maybe a portion of it. All right, so we also are probably very aware that there are payment issues in primary care, which is part of the reason we don't do some of those preventative services or some of the things that we think might help or benefit. As you can see on the slide, 41% of primary care services are not reimbursed by fee-for-service methodology, and those are the important things that would make a significant difference for these patients. If you do the follow-up phone call to that patient to just make sure they were able to get their medications, if you do a follow-up, quick telephone follow-up after they were hospitalized, just to make sure they're on the same medications that you had them on, that they were able to get services, to connect them with a specialist, to do any kind of care coordination in your office. The fee-for-service methodology doesn't really cover some of those things, and so that's part of what Patient-Centered Medical Home is attempting to do or attempting to influence. Second bullet point on there, payment for procedure-based care is often 3 times greater than payment for what we do in primary care. A good example is a 30-minute visit spent doing some type of surgical procedure versus 30 minutes in the office with a patient who was in a 10-minute slot that comes into you with 6 medical problems. And we all know, we all have those patients regularly. Last bullet point on there, the median income of primary care physicians is approximately half that of specialists. It's why we have a shortage of primary care in the United States. It's why people aren't choosing to go in, part of why people aren't choosing to go into primary care, and something that needs to be addressed too, or we will not be able to take care of that slide that I showed you that had the increase in chronic conditions. All right, so why do we need to change? Basically, we need to do something to help improve the quality and the cost of care. There is definitely a lot more evidence-based medicine and guidelines that we follow now than, for example, 20 years ago when people were practicing, and those things are typically measurable. And the good thing is that evidence-based medicine shows that those interventions will provide a different outcome. And it's good to hear that you guys are doing some quality improvement initiatives in some of the small practices. So that's what they're talking about. Lack of emphasis on prevention and healthy behaviors. Again, part of that is because that takes time. It's not reimbursed as well. It's a lot harder to do, especially when they're in there for an acute problem. Health insurance premiums are unaffordable by our patients. That's another reason we need to look at this. We talked about chronic disease incidents increasing. Let me talk a little bit more real quick about the dysfunctional reimbursement system. There are a couple of methodologies that are coming out now for patient-centered medical home. A lot of practices look at it as, why should I get accredited? What's in it for me? Because the accreditation process is actually very daunting. There's a lot of stuff that you have to prove that you might be doing already. That's what's in it for you to prove that you're doing that. And the hope was that if you are an accredited patient-centered medical home site, it might change your reimbursement methodology. So there's many big national projects going on related to that, and there's a lot of local projects going on related to that as well. And what most people are looking at is providing a per member per month fee or per member per year fee, some type of basically capitation or care management fee, so that you or your clinic can provide the services that aren't compensated based on an ICD-9 code or a CPT code or a fee-for-service system. A lot of organizations are also moving towards pay for performance or paying for quality. So, giving you additional funding if you actually took the time to improve your asthma measurements. So we can talk a little bit later if we need to about some of the models that are out there. And the last thing I wanted to put out there about why we need to change is satisfaction. Satisfaction in our jobs. Primary care providers are basically the only providers that have to know it all, have to know a little bit about almost everything. That is a daunting task with the amount of knowledge that's out there now that you are not only expected to know, but expected to do for your patients. And it's not going to be sustainable if we continue in the single patient face-to-face visit type of model. All right, so let me give you a little bit about the patient-centered medical home history, which you are probably aware of most of this. So I'm sure most of you guys are aware that it actually started through pediatrics back in the 1960s with the American Academy of Pediatrics and a medical home for children with special health care needs. So kudos to PEDS for first recognizing the need. It then sat dormant for a while. We went through some periods basically of HMO management, all kinds of things. And the chronic care model came out in the 1990s. It sounds like you guys are familiar with the chronic care model and using that as a base for some of your quality improvement projects. And in early 2000, they made some additions to some of the I don't know if requirements are the words or basically some of the standards of the chronic care model to include kind of community participation and care management. So again, that was another change that kind of it came before true patient-centered medical home. In 2007, there were 4 large groups that got together: the American Academy of Pediatrics, American Academy of Family Practice, the Internal Medicine governing body, and they came out with joint principles of the patient-centered medical home. And I'll go over those in a minute. In 2008 was when some of the recognition programs started. So basically a process that you can go through to be recognized as a PCMH practice and the steps that are required or what it means to be a patient-centered medical home. And finally, I don't know if you guys are familiar with kind of the last morph or the most recent morph of patient-centered medical home, and it's actually a term called health home. And this is basically being proposed, being worked on by CMS, and it's for Medicaid patients that either have 2 chronic conditions, have 1 chronic condition and a significant behavioral condition, have a persistent mental health condition, or are at risk of developing chronic conditions. So I look at it, and this is just my view. I look at it as patient-centered medical home is developing processes in your practice to take care of your entire population. Health home is almost like developing what you need for a specific subset. A specific subset of patients with either a behavioral illness or a chronic illness. Yes.
So, and it's true that a behavioral health entity can be a health home.
Yes. Okay. And they are, the government, the state of New Mexico is what's driving this or what's defining this, and they're basically looking at the behavioral health entities as health homes. Yes, a clinic or a facility could qualify as a health home, but there's there's much more emphasis in health homes on behavioral illnesses and kind of combining whole person orientation with that. Make sense? Mm-hmm. Is that a new concept that you guys have heard, or are people familiar with that?
A little bit.
Okay, perfect. All right, so let's talk about the joint principles real quick, which I'm sure you guys are also familiar with. So the patient in the patient-centered medical home, it was funny. The chief medical officer at Molina, she was telling me a story. She said that she still does some as-needed hospitalist shifts, and she says she was talking to a patient, and patient-centered medical home. The patient-centered medical home concept came up, and the patient told her, "Hey doc, I heard about this thing called the patient-centered medical home. Sounds like you're going to be coming to my home." And she had to look at that patient and say, "No, that's not really what the concept means." But it's funny because there's probably a much different knowledge base out there about what PCMH is in patients, in people that aren't in the healthcare community. But I would say, go back to your clinic. Ask someone at your clinic what patient-centered medical home means to them, and I bet you you will get 50 different answers as well. And that's okay. It could be 50 different things as long as it's trying to meet these 7 principles that are on the slide, or that were set out back in 2007. So patients still need a personal physician or nurse practitioner or physician assistant, and there's a lot of talk about those being OB-gynecologists as a patient-centered medical home. So this shouldn't say personal physician. I think it should say personal provider that basically directs their care or directs their care team. The second concept I'll talk about is physician-directed practice. Let's go back to that slide that showed the time needed to do all of this. A physician or a nurse practitioner or a physician's assistant can't do it alone. So we've got to be talking about what team could you have in your clinic, in your site, that could help you do this so that everybody's working to their appropriate level of licensure. Whole person orientation. We all have seen those patients that I take care of a lot of adults, so I'll use diabetes as an example. That diabetic that comes in to see me, I work with them month after month about improving their blood sugars. I can't affect their hemoglobin A1C, and perhaps it's because I didn't ask them, can you afford your medication? Do you have a good place to live? Do you, can you afford groceries, healthy groceries? Do you know how to eat? As long as we continue to ignore the biopsychosocial part of medicine, there might be some patients that we can't affect, that we can't touch. So that's what they're talking about when they talk about whole person orientation. Care is coordinated and integrated. We've all seen patients where we see them, we know they need to see the specialist or have something done, we refer them, and that's it, because that's the capacity that I have. I don't have a process set up in my clinic to connect them. They go home, they call the specialist, they can't get in for 4 months, they give up, that's the end of it, their disease or whatever progresses. In the patient-centered medical home model, the hope is that you create systems in your practices that actually help with that follow-up. How can you help that patient when they go home and call and there's a 4-month wait and you know they need to be seen next week? How can you get them the care that they need?
Incomplete command. Begin with the star key and end with the pound key.
Okay.
Safety and quality are hallmarks and should be the goals that we're trying to achieve. And then finally, again, back to payment. Payment for added value. You can't do this in your practice if you can't afford it. If we're still being paid based off of a fee-for-service methodology, you're not going to do this. There's no reason for you to, unless unless you have some time to do it for specific patients that really have the need. All right. I actually borrowed this slide from a presentation that was given by IBM. I don't know if you're aware, but in the, I think it was around 2007, 2008, IBM was actually one of the first employers that grabbed onto the concept of the patient-centered medical home model, and it's because they spend a significant amount of money on their employees for the cost of health. I think I read somewhere that they spend a whole month's worth of their revenue on health insurance and on health care for their employees. And so most employers have a very good reason to, to want to try to get into figuring out how do we lower our costs. And for those in your office, or for you, if you're not familiar with patient-centered medical home, this is what helped me get it. So, for example, in current care models, your patients may be those who make appointments to see you. All you see is them when they feel they have a need, but you're missing a large portion of the population. So in medical home care, your patients should be those who are registered in your medical home. Perhaps you're reaching out to those women who need a mammogram. Perhaps you're reaching out to those kiddos who haven't had their immunizations versus waiting for them to come in to see you. So in today's care, care is determined by today's problem and time available today. In medical home care, care is determined by a proactive plan to meet the healthcare needs. So if someone comes in for a sore throat, that may be the only time I see them that year, and that may be the best time to give them their referral for the mammogram, to schedule, to schedule their PAP or do their PAP, better yet, if you need to. We've got to figure out how do we start rolling in the preventative services to some of those care. I won't go through the rest of these, you can see them, but I think it's a great story of, today's care versus what it should be in the patient-centered medical home model. All right, I also put this slide in there because in the patient-centered medical home, you may develop in your site or in your practice different tiers or different levels of care. Not everybody is going to need that care coordination. Patients in Tier 1, which are well patients who could benefit from self-care, perhaps you create for them better ways to get access to your services, whether it be through telephone appointments, e-visits, nurse follow-ups, pharmacist clinicians. You would have to determine for your system, and I would also step back and say this is much easier for large practices who can work on economies of scale, work with the funding. Much harder for school-based health sites, much harder for single provider practices, but it can be done, and that's what the patients want. The patients want access to you, and it's actually more efficient to do things, not on a face-to-face visit or not on a model. So that might be what you might implement for your well patients. For those with stable or chronic disease, perhaps you put into place group visits for your diabetics, for your patients with asthma, for prenatal care. The possibilities are endless with that. And group visits are a benefit to patients because there's actually a phenomenon that occurs if the doctor's not telling them something and they hear it from one of their peers. At Presbyterian, we implemented group visits for multiple things, but the one that got me the most was with our diabetic patients. We had a group visit in Las Lunas, and there was a patient talking about, I'm having a hard time exercising. Another patient that was in that group said, hey, I know that I live by you. I go for a walk every morning. I will stop and pick you up on my walk every morning. That would have never happened in a face-to-face visit. Another one, a patient said, I've never had the guts to tell my doctor this, but I'm actually not taking my medicine because it makes me nauseated, makes me sick to my stomach. And another patient in the room was able to say, hey, you know what? I do this with the medicine. It did the same thing to me. Once I took it for a while, once I started taking it with food, I feel much better. And you can just get a little further than if it was their doctor because there's a different type of relationship when peers are in the room. The last tier that I would talk about is care management. I actually think that this is probably the most important concept or part of patient-centered medical home that we don't do in typical care models. And unfortunately, it does require some funding. It probably requires an extra RN, LPN. Sometimes you can get away with a medical assistant in your practice, but this is where the cost savings happen, and this is probably where the biggest intervention happens. And this is the person that can help the doctor so that the doctor doesn't have to do it all. All right, it's going to be a little bit difficult to see this one, but let me talk you through this. Am I doing okay on time? I probably have about 5 more minutes. Okay.
Thank you.
All right.
Great.
Perfect. And let me tell you where I pulled this one. This actually came from the Colorado Collaborative. And I don't know if you guys are aware of what happened in Colorado, but I think that they are probably one of the most progressive states regarding healthcare. when patient-centered medical home first came out, they, and I don't know how they did this, and I can't even envision it happening here in New Mexico, just because of the divisions between everything. But basically, the large medical groups got together, the providers that were interested got together, they got all the payers together, the MCOs, and they got the government together. And they all sat down at the table and developed a patient-centered medical home model for the entire state of Colorado. And so they have things such as agreements. For example, the patient-centered medical home practices have agreements with the specialist, and they only refer to specialists who agree to comply with their model. And one of those things is you will get a note back to me. If I send a patient to you, I will hear back from you about what happened at the practice. And those are kind of key concepts in patient-centered medical home. So that's where I pulled this from, but this actually talks about a visit that might happen at a site or at a clinic. And so currently in some of our practices, what happens is the patient is on the schedule and the patient gets roomed to come in to see you. That doesn't at all facilitate you being able to do all of the things you might need to do for the patient. So there's many pieces before and after the visit that should happen in a patient-centered medical home model that might help you. For example, in the upper left-hand part of the screen under number 1, before the visit, the patient has to have access. Perhaps you can even prevent a visit and save it for someone that's sicker by taking care of their need over the phone, by a nurse talking to them, by email like we talked about before. You know, multiple ways that you can think of to deal with the patient's need that might prevent them from coming into the office. Also before the visit, on the right-hand side of that, it talks about prepared care team. For example, if they're coming in to follow up on a hospitalization, if they're coming in to follow up on an x-ray, you need that report available to you. It will save you as a provider time if you don't have to walk out of the room, try to find it in the EMR. You know, all of that should be prepared. And sometimes that happens by having a huddle in the morning or some type of little conference with your staff to talk about, hey, I know this person's coming in, can you help me? Can you help me get that piece of information? So if you go down to during the visit, front office can help with a couple of things. You know, perhaps they talk to the patient about their insurance, make sure that patient that needs, that needs their depot is still on Medicaid, or, you know, help get them assigned or get them back enrolled if needed. The nurse or medical assistant could be part of your team. Again, gathering information. Perhaps, again, let's use that same example of patient coming in with a sore throat. If you develop protocols in your practice, that medical assistant would realize, hey, this is a female, she's in this age category, I don't see a mammogram in here, I'm going to prep the form for a mammogram for my provider. That way, it's very easy for the provider to just verify, sign off, and take care of that sore throat versus ignoring it altogether. So lots of things that can happen with the staff helping prepare the visit. I won't go into the rest of the details on this, but let's talk real quick about after the visit. After the visit, there's a significant amount of work to do as well that we don't typically do in the practice. You know, again, using the example of having them see a specialist. Most practices, if they are accredited, one of the requirements by NCQA is that you have a process to follow up on lab results and basically on labs and referrals. And so let's say, for example, you referred a patient for a mammogram, they had a mammogram done, there was an abnormality, and that didn't get back to you. Legally, you're liable for that. Or worse yet, it got back to someone in the EMR and nobody looked at the report or nobody found that problem. And so there's a piece of closing the visit, or basically closing the practice, to help improve the quality of care in this model. All right, so this slide just talks real quick about basically about primary care redesign, and we've talked about most of the things that are on here. The only thing that I'd add that we haven't talked about is basically basically how the patient-centered medical home model approaches the patient. There is a lot of talk about informed decision-making, so it should be our priority, or it should be our responsibility in primary care to help prep the patient, or basically help them make an educated decision about things. I like to use the example of orthopedics. If you, let's say someone comes in with knee pain and they have significant osteoarthritis, and you refer them to the orthopedic doctor without setting up the conversation that there are alternatives besides surgery, they will see that orthopedic doctor. The orthopedic doctor will do what they are trained to do. They are trained to do surgery. There is a possibility that patient would go through the process and would have surgery done. Well, who in that process had the conversation with them about physical therapy, about about weight loss, to get some pressure on your knee? Informed decision making talks about educating the patient. They don't necessarily need to know all of the medical criteria, but you can help them make a better decision sometimes because there's options. The other thing I would point out is self-management education. Again, because of time constraints, sometimes we're not trained as well with, with motivational interviewing, with those types of skills. I don't know in primary care that we do enough or that we do enough teaching on self-management for the patient, which really benefits the patient in the long run. All right, so let's talk a little bit about some of the published data that has come out regarding patient-centered medical homes. A lot of organizations have published data that they've been able to reduce inpatient stays, reduce readmissions, reduce ED visits, reduce urgent care visits. Tons of cost savings related to this, which is why most of the major insurance companies are interested in funding this, because the savings, those types of savings, sits on the side of the payer, and we've got to do some type of cost sharing or be sharing those savings with the practices who are actually doing all the work. The other thing I pulled and I wanted to put in here, because I think all of us that provide care in this room are interested in it. For example, group health, they were able to prove that this model of care decreases staff burnout and improves provider satisfaction. That's one of the things that's important to us that we're looking at. Geisinger put that they saw a 74% improvement in quality of preventative care using a patient-centered medical home model. Capital Health in Florida said that there was a 250% increase in primary care visits. And you might say, well, wait a minute, I thought this model was to decrease primary care visits, but honestly, those increases may come from patients that were inappropriately using the emergency room, inappropriately using the urgent care. There is better continuity for most things if they're seen by a provider that knows them, if they're seen by a provider that has all of their records, if you don't repeat the chest x-ray just because you couldn't find it, if you know their list of medications. And so it's actually a good thing that the primary care visits increased. And the last one I'll point out is Health Partners in Minnesota, 10% decrease in diagnostic imaging scans in the first year. And you might say, oh, that's another cost measure. They're only interested. But look at the amount of radiation that patients are getting related to that. Okay, let me talk a little bit about patient-centered medical home recognition programs. That I think that now they are up to about 20 programs out there that are doing recognition. NCQA was definitely the leader, but there are more coming on. And I would also say that most organizations choose to go with the accrediting body that they already use. For example, the last one on there, AAAHC, that I have to look that up because that actually stands for Accreditation Association for Ambulatory Health Care. Some of the minute clinics, some of the smaller clinics use that accreditation board versus JCO or versus NCQA.
FQHCs do too.
FQHCs, okay. So they offer basically a recognition program as well, and there are cost savings if you already use them for other types of accreditation. So that may be why someone might choose that. AAAHC is actually the only organization of recognition programs that requires site visits. So everybody that applies gets a site visit. I don't think there are forms you have to fill out for that. Basically, they just come to your site and they have your checklist and they look for what you are doing. Unlike NCQA, which only a portion get a site visit, and it's all about sending them documentation that you do the process. There's been two versions of NCQA. Now, basically, everyone has to go with the 2011 version. They changed things based on feedback from a lot of practices. The first NCQA recognition program had a very heavy IT emphasis. So basically, if you didn't have an EMR in place, you were going to be a level 1. If you had an EMR in place and all the other parts of it, you would be a level 2. They say they decreased it and it's less burdensome. In the new guidelines, it's 40% IT related versus 46% related, but it's still a pretty heavy IT emphasis. The other major difference between the new NCQA recognition is they are now offering an extra distinction if you report patient satisfaction data or use the, I don't know if you're familiar with the SIGI CAPS survey. It's a survey that's been used for a long time by health plans. I think it was in July of 2012, Doctor? You remember? Was it 2011? When they came out with the PCMH one?
The caps, yeah.
Yeah, I can't remember.
Recent. I think it might have been
Was it 2012?
Yeah.
And basically it asks patients questions like, were you able to get in to see your provider? You know, do you have the resources you need to control your chronic disease? So questions that are more related to what we're trying to influence with patient-centered medical home. And then JCO also offers a recognition, and I put that on there as well. All right, I just wanted to end with this slide here. I went to a conference a couple of years ago and they had the coolest buttons that said "End Medical Homelessness," and I thought that was cool. And so I hope that all of us here in some way or another, and that doesn't mean that you need to go through some type of recognition process, use something from this model to help improve the care to patients that we're giving. So.
Thank you so much.
You're
that was
welcome.
so great. Very informative. And I guess now I would just like to open it up for people if you have questions. I have one. We did a presentation early on in Q-Tip about working to the top of your license and find that to be challenging within practices for people to figure out where they can step all the way up.
Yes.
Or am I stepping on somebody's toes? Worried about consequences rolling downhill,
yes.
That kind of thing. Do you have any advice or thoughts on how a team might start with that?
So implementing a patient-centered medical home, we ran into that as well. And I would say that there's probably roadblocks or barriers at many different ways. The provider, you know, it was actually shocking, but the provider was the biggest roadblock or the barrier. They're used to doing some of these things and didn't want to give it up. Yeah. You know, didn't want to let their nurse, who, you know, is very knowledgeable and able to do this, you know, do that for them, basically because we had to work on the trust issue or the relationship. So I would say that that's key. You know, figure out if that's what's going on, and if so, you know, try to determine how can you build that bigger trust. And is it, you know, maybe the provider just reviews or looks at a couple of things being done by the nurse, or, you know, I don't know what that might look like, but, you know, somehow figure out how can you give the provider the okay, that it's okay to give away some of those things. The other thing I would say, you know, we ran into some barriers when, you know, the nurses were very busy. The medical assistants were very busy as well. And so the other thing we had to do was figure out what could come off of their plate. Because if we're asking them to do more, they're already overwhelmed, already busy. You're just basically shifting it. It won't work unless something comes off of their plate as well. So I would say look at the duties, look at the skill set of everyone. And the last thing that I would add to answer that is you have to look at it as an opportunity. I mean, that medical assistant might be tired of just putting patients in the room, typing things in. They might love the opportunity to do something new that uses more of their brain, that's, you know, that basically uses them to the highest level of licensure. Same thing with the nurse. A nurse can do probably a lot more things than we use them to do. And so look at it, and when you present it to people, present it as an opportunity for them to either grow their knowledge base or to, have more interest in their job.
Mm-hmm. Thank you.
Other questions?
So what, in your experience at Press, what were the biggest hurdles in implement? And I have to say that I've been a patient at Press for a number of years, and it's been really obvious the changes. And I feel like the customer service at Press has improved enormously.
That is good to hear.
And I, as a patient, I really appreciate it. I think that the EMR has been difficult. And my physician is not young. She's not old, but she's not young. And so it's been, obviously difficult for her. But from your perspective, kind of working with the system, what were the pieces that were most difficult?
Honestly, and I hope I can share some of this stuff, the biggest hurdle was actually changing reimbursement and changing the way we pay the providers. We started out with this by, the providers at Presbyterian are basically paid, you eat what you kill. However many patients you see, that's what affects your paycheck. In that type of model, you cannot incentivize them to take the time to do this stuff. And we tried to put processes in place with the EMR. We tried to create a registry. We tried to create, some nurses to help support the quality improvement. And it didn't change because the incentive wasn't there. The big incentive wasn't there. And so the biggest hurdle we went through was changing the compensation for providers. Just like, you're talking about changing the reimbursement to your practice from a fee-for-service, we actually changed the payment to doctors. They still get paid based on fee-for-service, on how many patients they see, but now there's a portion of their pay that's based on panel management to allow them to take the time to do these things and not worry, my paycheck's going to go down because I'm not seeing patients in the room. And we also added pay for performance or quality, and that's hard to do.
So how did you do that? How did you decide what the performance indicators were, and how did you go about that?
So there is, now that it was hard, early on in patient-centered medical home, organizations weren't publishing their data, organizations weren't talking about how they're paying their providers. There's a lot more literature out there, a lot more data out there now. So if you're looking at something like that, what I would say is look at the literature of the organizations that have published it. I think that, and we basically looked at national data on what are PCMH organizations doing, and we're able to find, based on that research, based on that literature, it looks like about an 80%, 20% mix is what most organizations are working on. 80% fee-for-service, 20% based on other things, and your other things might be different based on your organization. Perhaps you're an organization that has a lot of children, and asthma is, one of those high cost, one of the places where there's an opportunity for improvement or opportunity for savings. Then asthma might get in your measures somewhere. Perhaps you're an organization that's already taking care of a lot of patients outside of the office, and so you might not need as big a panel management fee, or you might not need as much time to do that. So it's all based on your organization, and by no means did we say one day you're getting paid this way and tomorrow you're getting paid that way. We went through actually a 1.5-year process of shadowing. In the new payment model, here's what you would get paid. In the old payment model, you're currently being paid in the old payment model. We're going to do that for a 1.5 years, but we showed it to you for a while so that you're less worried that it's going to affect, and you can take that time to make the change in your practice. And that I'm not at all saying that I know the best way to do it, but just some thoughts and lessons learned. But there's good literature out there and organizations willing to talk about what they've done and share what they've learned along the way.
So is the end result that doctors make about the same money, but the quality goes up?
That was the intention, and the other thing is...
And did you get there?
Not there yet, but it's in the plan. The other thing, the good thing that's happening related to all of this and related to what's going on nationally is primary care salaries are increasing. And so the other thing that you could do is put those increases towards your percentage for pay for performance or quality. So instead of putting those, those regular increases towards the fee-for-service portion of their pay, over time, if you continue to put those increases in this other bucket that you need to fund, you will get there. And so, no, we didn't get to the right percentage yet, and it's because, again, you will have a lot of providers leave if you do some type of takeaway. It's a progression. Other questions?
Yes. Everyone, this is more political. Now that the announcement has been made about Centennial Care,
yes,
do you foresee that could possibly lead to more collaboration like there is in Colorado?
Definitely, and I think it's a good thing. I think that the players that were chosen for Centennial Care all are ready, showing their interest in patient-centered medical home, all have processes, projects, collaborations in place, and so I think it's going to be a good thing. The other thing is there are a lot of things in the Centennial Care contract or in the proposal that the state is requiring to move organizations and providers in the right direction. So we finally got some help from the government to move things the right way.
Right.
So I think it's a good thing.
I have a question that might just be a result of immature understanding of some of these concepts, but back when Medicaid first became a managed care model, in 98, I think, at least in the behavioral health world, when it switched from fee-for-service, which tended to proliferate high-end services, into a managed, a capitated rate kind of per member per month model, one of the things that really happened in the behavioral health world is that there was a disincentive to provide services because the incentive was to keep the money. And I'm wondering what is built into this system that can prevent that from happening? Because that just really crippled the service world.
Yeah. So I look at it as a continuum. We have strict fee-for-service, and then you have the HMO model that was prevalent in the 1990s. My hope is that accountable care, which is the term, the term that's being used now versus HMO, my hope is that accountable care is probably a little bit more in the middle. For example, things in the Centennial Care contract. Even in that contract, or the hope is that people will be paid not just fee-for-service, but with some portion of panel management. I think we learned a lot from that, and my hope is that the pendulum is not swinging all the way to the right, but only a little bit to the right. It's going to come away from fee-for-service, and who knows, 5 years down the road, we'll probably be back that way, but I don't think it's going to swing as far as it did in the 90s, because there were lessons learned.
I have a question. As a practice that is trying to transform their practice into a patient-centered medical home, what did you find to be the ratio? Because obviously you need to hire more staff or shift the responsibility. Can you kind of tell us what your experience was when you tried to implement that at Presbyterian?
Okay. So let me step back real quick and talk a little bit about the people that were on the care team that we created, because each of them had different responsibilities. We integrated behavioral in some of our sites with behavioral health. In the past, behavioralists were on site, but they were basically co-located or shared office space. With behavioral health integration in PCMH, those behavioralists had time on their schedule that was available for warm handoffs. So if I was seeing a patient that had depression, I could walk down the hall, introduce them to that behavioralist, and that's what we talk about when we talk about the integrated behavioral health. it significantly decreased no-shows because they had met that person. They saw that their provider agreed, their provider worked with that person, and it also helped increase collaboration. And so that was one of the members of our care team. We also used pharmacist clinicians. I don't know if you guys are aware, but New Mexico is the only state that actually licensed pharmacist clinicians. Pharmacists can go through a special type of training or additional training beyond just their pharmacy degree and become licensed for certain disease states. They submit their protocols to their board of pharmacy. They have to have a doctor that's their supervising physician, and pharmacists can be used to help take care of diabetics, cardiovascular disease, CHF, all anticoagulation, all the things that physicians are taking care of. And again, the hope is people are working to their highest level of licensure. And so they were part of our care team as well. We used case management and care management. I talk about case management as the nurses that helped us with patients that were high utilizers of the system or high cost, and care management as helping us with chronic disease states. So those are the nurses that are helping you run your registries or reach out to those patients that are due for certain types of services. And then there were members of the care team within kind of the pod or the practice site, like your medical assistant or your nurse, that were helping triage calls and take care of them if they could, helping room the patient, helping you get those resources. And so to answer your question, we played around with the staffing ratios, and at the beginning we really didn't have a clue and just had to say, oh, I think this is what we need, and then it morphed. And what morphed was the duties that each of those people had in the practice based on finding out, oh, we don't have enough of that, we maybe need to shift tasks to this other member of the care team. Does that answer your question? So as far as I'm aware, there's not literature out there that says this is the right number staffing mix.
Yeah, Steph. And so each of your care teams had how many just one provider or a group of providers?
Technically, we talked about each of our care team having one provider and the support staff working with that one panel, but realistically what happens is it was usually a smaller group of 2 to 3 providers. That way, if that provider was off and their patient needed services, they at least see a provider that's that's a little more connected or in that care team, or are not seeing multiple different providers. So it ended up being
like
care teams of 2 to 3 physicians, and then sharing the same staff, sharing a couple patient panels.
That's great. Any questions from the cyber audience? Okay.
Is that somebody?
That's what. Okay. Well, if we have no more questions, we would like to say thank you very much to Darcie for this presentation. It was really good. And see you next month for Lunch and Learn. Thank you.
Thanks. Thanks, Darcie. That was great.